Welcome again all. This is our last session for the Neuro Anatomy MCQs. Welcome to our YouTube channel Anatomy by Doctor Ankit, and here we are doing the MCQs. Let's start with this last session of the Neuro Anatomy MCQs. So here we go. The first MCQ for the day. A 64-year-old man comes to the physician because of sudden onset of visual impairment, right? 64-year-old man with visual impairment. He has a history of hypertension, coronary artery disease, and type 2 diabetes. Visual field testing reveals a defect in the left half of the visual field for both eyes with sparing of the central acuity. Occlusion of which of the following arteries is the most likely cause of this? So here, if you look at the question, right? So there is some visual impairment with the comorbid conditions like hypertension and coronary artery disease and diabetes. Visual field reveals a defect in the left half of the visual field for both the eyes. Okay. So if you remember, we also did a sort of similar question where we drew this two retinas, and this was the nasal hemiretina. They used to cross each other at the optic chiasm, and this was the temporal hemiretina. They used to go to the same side. Now visual field is lost on the left side, meaning by that if a person is standing on the left side, then we can imagine that the left side lateral visual field is stimulating the left eye nasal side hemiretina, and the right eye, this on the left side visual field, it is stimulating the right eye temporal hemiretina. And if you look at both of them are going where? If you trace this and this, they are going to the right side, meaning by that any defect that is distal to the optic chiasm over here will lead to the contralateral homonymous hemianopia. Okay, so it leads to contralateral homonymous hemianopia. Fine. So if there is a left half visual field, it means that there is a right side right side there is a defect distal to the optic chiasm leading to left side homonymous hemianopia. So there is a problem in the, for the artery purpose, it is problem of the right side. If you look at the options left posterior, so we can easily rule out options A and B. Then they are saying right posterior cerebral artery, absolutely correct. Why? Because right posterior cerebral artery is supplying which area? It is going to the occipital lobe. It is supplying the visual cortex, right? And the right side obviously supplying the right visual cortex. That is obviously distal to the optic chiasm. So when this right posterior cerebral artery is supplying the right visual cortex, problem in the visual field will be on the left side, contralateral. Left side there is hemianopia, right? So left side hemianopia. And they are also saying sparing of central acuity. This is because the macular area is also supplied by the middle cerebral artery. So that part will be spared, right? So answer is our right posterior cerebral artery. If you look at the option D also, they are saying left middle cerebral artery, again left side we can rule out easily. Therefore answer is typical our option number C without doubt. And if we see this image, kindly take a screenshot of this image, very important image. Here they are showing us the left and the right eye. They are showing us the optic nerve over here, optic chiasm over here, and this is the optic tract over here, and that is going behind into the visual cortex. Here the numbers are given, kindly focus on the numbers. One number is what? One number is the right optic nerve is damaged. You can see the anopia in the complete right eye. Number 2, we did a question on the adenohypophysis, pituitary adenomas. It leads to bitemporal hemianopia. You can see option number 2, bitemporal hemianopia. Option 3, if you see the right side optic tract issue, left side homonymous hemianopia, you can see over here, left side. Option number 4 is Mayer's loop. So when there is a Mayer's loop problem, option number 4 or option number 5, different levels, you can always see in option number 4 and 5 also, problem is on the right side, the visual field defect is on the left side. The only problem is when it is involving the Mayer's loop, that is going through the temporal lobe, it is involving the superior quadrant. While if it involves the upper part of the tract, it is involving the inferior quadrant. That's the only issue. Option number 6 over here, see if PCA infarct, PCA, in fact, that was our question. So this is actually our question, current question. So if we go with this, we have what? We have the macular sparing. Why? Because we said that area is supplied by the middle cerebral artery. So that is option number 6 over here. And 7, they have shown about the central scotoma as well. Very important question for the optic tract pathways, right? Okay, let's see the next one over here. 5-year-old demonstrates persistent food seeking behavior. 5-year-old child. So in the beginning, the parents or the grandparents might be very happy that okay, he's having a lot of food, fine. But soon he is obese. Mother reports some aggressive and bizarre behaviors. Now mother is slightly concerned. Obviously, mother knows best for their child, and they're the first ones who actually notices some altered behavior or disturbances in the child. So mother says that he is exhibiting aggressive, bizarre behavior apart from persistent food-seeking behavior, which led to obesity of a 5-year-old. These clinical findings may be explained by lesion in which of the following hypothalamic nuclei. Okay, so the thing over here is that problem they have specifically asked, think of a nuclei in the hypothalamus, hypothalamic nuclei. Think of a nucleus whose destruction is leading to what? Increase food intake. Whose destruction is leading to increase food intake. It means that this nuclei should have some satiety, or there's a feeling of okay, my tummy is full. That feeling is known as satiety. So if your feeling of satiety is lost, then you don't know when to stop. You keep on eating. That is bizarre behavior leading to obesity. So what is that satiety nucleus? The satiety nucleus, we look at an image now, right? We look at an image. This image is for the hypothalamus. You can see this whole is hypothalamus over here. Look at the different nucleuses over here. If you look at this ventromedial nucleus, its main role is satiety center, and its destruction leads to obesity. Okay, so there are a few nucleus that you need to understand. First of all, this ventromedial nucleus, that is actually our answer over here. If you look at the question, this option number D is our answer, right, without a doubt. But if you look at other nucleus like suprachiasmatic, what is that for? It is for our biological clock. It is for our biological clock or circadian rhythm. Supraoptic, so supraoptic paraventricular, they are for vasopressin and oxytocin release, right? Lateral nucleus has other functions. Here we are seeing, so the nucleus, like lateral nucleus, what will it do? It is for the stimulation, for hunger, just opposite of what is the ventromedial. So medial nucleus, ventromedial or medial nucleus, its major role is satiety, feeling of fullness, while lateral nucleus, it stimulates hunger. When the person is not having a food for many hours, like 4, 5, 6 hours, then slightly lateral nucleus is stimulated for hunger. When the person starts to eat, then it is a ventromedial nucleus. Okay, so remember that. Fine, let's see the next one over here. A 43-year-old complains of double vision when walking down stairs. Now, if you have practiced the previous year question, this much line is sufficient. Think of which cranial nerve is involved over here just by reading the first line. Walking down the stairs, double vision. Reading the newspapers, finding difficult to read the newspaper or your textbooks. So when the person starts to look down and tries to focus, there is double vision. This is which cranial nerve abnormality? Is it third, fourth, or sixth? These are the 3 cranial nerves which are motor to the extraocular muscles. He has no other concerns. He eats a balanced diet and takes 1 multivitamins. He jogs for 30 minutes every morning. Past medical history is significant for type 2 DM. In a 43-year-old male, okay, not a very big deal. A lesion of which of the following structures is most likely responsible for this patient complaint? Now, reading the first line should arise that it is a 4th nerve issue. 4th nerve issue, right? 4th nerve is your trochlear nerve. Supplies what? Supplies SO. What is SO? SO is the muscle superior oblique. What is the function of superior oblique? One thing is it depresses the eye, right? Second function, or you can say the primary function, if I want to put it in other ways, the primary function is not depression. The primary function is intorsion of the eye, intorsion, moving inside. Okay. Secondary, the second function is depression of the eyeball. Depression of the eyeball. And the third function will be abduction. So that is the primary, secondary, and tertiary actions. This is primary action, secondary action, and tertiary action. So most important action is this, then comes this, then is the abduction. So then the fourth nerve is not working, then it leads to this problem. Now they have over here, they asked, okay, can you identify the fourth nerve out of these A, B, C, D, E? Let us try to find it out. Shouldn't be a very big deal, but still. This is our nerve number 1, olfactory. This is nerve number 2, that is optic. Okay. Then this is A option over here. If I put it a different color, this is oculomotor, third. Then this B option, this is the fourth nerve, and that is the answer. So actually the answer is what? Option number B over here. Option number B, it is the fourth cranial nerve. Come back over here, right? So option number C is the thickest nerve, fifth trigeminal. Option number D is sixth nerve. Option number E will be the seventh nerve. Then lateral to it, this might be the eighth one. This will be 9th, 10th, 11th, and this over here is the 12th nerve. We have done a question regarding this, or we'll do it further on also again in the head neck section. So basically answer is number 3, but understand, double vision when walking down the stairs, focus on the fourth cranial nerve supplying the superior oblique muscle is the culprit over here. And let me show you an image as well over here. What is this image? These, if we label A and B, this is normal, and if we label this C and D, this is abnormal. What is happening over here? Here is, you have the fourth nerve palsy. Here we have the fourth nerve palsy. Now see what is happening. If you look at this image, option number A, when we look straight forwards, both eyes are aligned right and left. Suppose this is right, left, right and left. Both eyes are aligned. Now suppose the patient tilts the head to the left side, as you can see the image B over here. What happens is the right eye actually E for extorts and the left eye I for intorts. You can see very well, to keep both the eyes in alignment. Okay, so right and left eye, this is normal. This whole is normal over here. Fine. This is how it actually happens in a normal individual having a normal functioning of the extraocular muscles. Fair enough. Look on the image number C and then D. First look at C. In this image, there is fourth cranial nerve palsy. Fourth cranial nerve palsy. On which eye? On the right eye. So what is happening in a normal, when the person is looking straight, then as the main function of superior oblique was what? Primary action was intorsion. So this intorsion will be lost, and we know that our body works on balance. When the intorsion is lost, the eyes go to extorsion. You can see the right eye is extorted outside. Okay, so what happens? When does the right eye extort? When you tilt your head to the left side normally. So in this patient, the eyes will be the head will be automatically tilted to the left side, so that the left eye also intorts and this is already extorting, so they are aligned. So suppose a patient comes to the right fourth nerve palsy, his head will tilt slightly like this. If you ask the patient to look straight like this, then there will be some diplopia, double vision. He will be okay. Now he will say, I'm comfortable like this only. In this way I can look better, and if I start looking like this, some headache starts to start. This is a very important point to understand, right? So head tilting to left side, right cranial nerve, fourth palsy. Okay, here all the cranial nerves are already, again you can say again labeled over here 1 to 12, as you can very well see. Let's see the next question over here. Which Brodmann area represents the somatosensory cortex? Basic question. Sometimes we read so much that we forget the basics. Central sulcus. This over here yellow is the sensory cortex, and this slightly greenish color is the motor cortex. What is the Brodmann number over here? For this yellow part, it is Brodmann number 3, 1 and 2. For this motor part, it is Brodmann number 4. The answer is very straightforward. Area number 3, 1 and 2. Let us see over here. This is the sensory, that is a motor area. This is the left side somatosensory or left side superolateral surface, and here are the Brodmann number. You can very well see 3, 1, 2 for sensory, area number 4 for motor, primary motor, 6 for premotor, 44, 45 Broca's, area number 22 over here Wernicke's, 14, 42 auditory, 17 visual, 18, 19 secondary visual. Okay, some of these few points. 6 is what? It is frontal eye field, horizontal reflex. Let's see one more question. Which of the following is the most likely level for the insertion of a needle for performing a lumbar puncture? Again, very practical question and straightforward question. But if you have seen or done LP, it would be a cakewalk. Normally when we go do an LP, we look for both the iliac crest and look for a plane which is passing through the highest point of the iliac crest. That is what is known as the supracristal plane. And we say it is around say L4, L5, and this is where the needle has to be placed in the midline of a flexed trunk. So the needle passes easily into the cerebrospinal fluid, subarachnoid space, into the cerebrospinal fluid. Answer is straightforward without a doubt. It is L4, L5. Okay. So we should know that the spinal cord ends at around lower L1, and then below L1 there is a lumbar cistern which is around S2. So you can say from L2 to S2 we mainly have what? We mainly have the cerebrospinal fluid. Okay, and obviously the cauda equina. So we take somehow in the middle of it, that is around L4, L5. Because below L5 it is S1, S2, above it is L3. You can imagine yourself that this point is somewhere around the center, and your needle should pass over here to do a lumbar puncture. Now the other questions that do come is, what are the various layers that your needle will pierce, right, while draining the CSF? Obviously after skin and the superficial fascia, your needle passes through some ligaments which are worth noting. What are those ligaments? Supraspinous ligament, then interspinous ligament, then ligamentum flavum, then you enter into the dura mater, right, and then through dura you enter the arachnoid, and now you are in a subarachnoid space, and you are basically dealing with the cerebrospinal fluid over here in the subarachnoid space. So there is supraspinous ligament, there is interspinous ligament, there is ligamentum flavum. Where is this ligamentum flavum? Ligamentum flavum is present where? It is connecting the laminas of vertebrae. Laminas of vertebrae, right? It is quite elastic in nature. Fair enough. Let us see one more over here, probably the last, and I wish you all the best. The question says that a 49-year-old lady presents with seizures and ill-defined neurological complaints. The examination reveals a bruise on the lateral aspect of the head immediately rostral and superior to the ear. Right, bruise over here. A CT shows a large AVM, arteriovenous malformations in the area of the lateral sulcus. Lateral sulcus was what? We were making the brain like this. This area is actually our lateral sulcus, right? This was the central sulcus. So what the CT showed was an AVM in the area of the lateral sulcus. Which of the following most likely represents a major draining vein? Now they haven't asked the artery. If they would have asked the artery, we all know that you have this MCA, middle cerebral artery, M4 segment coming out of the lateral sulcus, supplying the lateral part. But no, what they asked, can you name the vein over here? Which veins lie over here? Let us see the options. Inferior sagittal sinus. It is actually an unpaired sinus. Closer to the medial surface, cross. It can't be the answer over here. It is lateral. Internal cerebral, it is already saying I'm placed internally, right? So this internal cerebral vein, it drains the medial or the deeper parts of the brain, like the thalamus, and those areas, and they form the vein of Galen. Ophthalmic vein is what? It is draining the eyes, draining the areas of the orbit. Obviously without reading the option, we know answer has to be this, and actually it is superficial middle cerebral vein. Which artery was there? Middle cerebral artery. Vein accompanying it is middle cerebral vein. That why superficial? Why? Lateral sulcus outside. Let me show you an image over here. This is of the lateral surface. Now I will show you the vein which was a superficial middle cerebral vein. This is the superior sagittal sinus that you can see over here, but the inferior is more medially, right? Then there are two other things in this image that you need to know. What are those? Trollard and Labe. What are these? There is a great anastomotic vein of Trollard over here. What is it written? Trollard. This one is the Trollard, right? It is connecting the superficial middle cerebral vein to the superior sagittal sinus. And then there is the inferior anastomotic vein of Labe. It is connecting the superficial middle cerebral vein to the transverse sinus over here. Okay, so remember these two names also, Trollard and Labe, they might be asked. So that's all for the neuroanatomy important MCQs and the topics. I wish you all the best. Do watch other previous videos of the upper and lower limbs, and in the next week from Monday to Friday at 8 p.m. we will be coming up with other interesting MCQs and the topics around it. That's all from my side. I hope you guys are enjoying. Thank you, and see you soon. Any queries are more than welcome. Don't forget to like the video and share and subscribe if you are enjoying it. That's all from my side. Bye bye. Take care. See you soon.